Hello everyone, good evening. So finally the time has come for your final year part 2 examinations. So dear students, there are hardly few days more left for your exams. So definitely you would have covered all the portions and definitely the last minute revisions would be going on. I assume so. And you will be making sure that every question bank, every past year questions are being looked into. Right. So to make your oral surgery preparation a little more easier, I'm going to present today some 10 difficult questions which come in the exams very often. Some are short answers, some are short essays, and especially the previous year long essay, which was a little surprise for the students, that is recent advances in local anesthesia. So that's a question, especially I am going to discuss today. So dear students, as the instructions has been given to you, right, in the WhatsApp group, all do's and don'ts. So I assume that you had your dinner and you are absolutely in the study mode. Make your notes open, pen should be ready, and if you're watching through laptops, just put your mobile phones in the vibrator mode. Okay, so dear students, you are just 10 days away from your exams. So you have got 4 subjects, that is your prosto, conservative, pedo, and oral surgery. And oral surgery happens to be the last exam. The fourth exam is oral surgery. So definitely you have got just 4 or 5 days more to read oral surgery, and then you will be switching on to your first exam, first paper, that is prosto. So in oral surgery, as per the severity or the importance of the chapters, do not forget to do fractures, TMJ, orthognathic surgeries, right? And then your impaction, extractions. These are the 5 common topics which they ask main questions. And every year, local anesthesia comes for 15 marks. In Kuhas University, 15 to 20 marks is from local anesthesia. And what are the questions in local anesthesia? Define local anesthesia, describe the theory, and the 3 blocks, generally posterior superior alveolar nerve block, posterior superior, inferior alveolar, and infraorbital nerve block. Apart from that, open mouth and closed mouth technique, that is Gauge technique, Vazirani Akinosi technique. And then your complications of local anesthesia. Local and systemic complications, any one of them can be 3 marks or in total can be main question. So 20 marks is local anesthesia, which you can always put it in your pocket. So the remaining part you are reading for the 50 marks. So today we'll be starting one by one. So I hope everything is set. So let's start our session for day. In between, I will be giving you micro breaks that will be just around 45 seconds to 1 minute. And then we will again start with the new topic. Whatever your doubts are there, queries are there, you can put it in the chat box. I'll try to answer towards the end of the session. If the doubts are more and not able to finish on the speculated time, then you can put it in the WhatsApp group. I will personally reach to each one of you through WhatsApp group. Okay, so let's start our session. Okay, so dear students, you all are going to become a dental graduate, and definitely after the graduation you will go for post graduation also. So you will be called as a dental surgeon, not as a dentist, dental surgeon. So to be a good surgeon, you must have an eagle's eye, a lion's heart, and a lady's hand. So the perfection should be there like that. And especially when it comes to oral surgery, every case, every extraction case is an exam for you. It's not that practical exam day you have an exam. Every case is an exam. The patient will give the judgment how well you are. Okay. So now it's the theory exam time. Let us go back to the theory topic. So hi everyone, this is Dr. M.S. Balakrishna, professor and head. I'm an oral and maxillofacial surgeon. So I have been associated with Dental Pulse book, one of the contributors from a very long time. I am part of various coaching centers. So right now I am heading the EDN2 Director of Competitive Examinations. So now this EDEN2 platform is, along with the Association of Dental Students Association, is bringing this revision series. So I request all of you to make the most of it, of all subjects. Okay, so let's start. So dear students, what got you here may not get you there. So this is a very common proverb which I almost share in every class. With whatever hard work and energy you have reached to final year part 2, if you continue to do the same hard work, you will not go to the next stage of your life. You always need to put extra. And this last 10 days is the defining moments in your life. Whatever you have studied in first BDS, second BDS, third BDS, it's all one side. And this 10 days, which you're going for final year exams, it's the entirely equivalent to all the rest of your 4.5 years or 3.5 years, whatever you have studied. Please understand, there is no elevators to the top. There is no escalators. You will have to fight it out. And everyone has done it before you. People will do it after you. But for you, this is, many of you, this is for the very first time. So make sure this very first time is the best preparation and the best examinations you are going to write. And once you write the exam, you should be super confident. Yes, I will pass. Okay. So let's start now. The story of all of us. We always think that dentistry is very easy and we always want to be on the top, right? But when we start preparing, it's always a delay is there. And the survey says that most of the dental students start their study from tomorrow. But I am 100% sure that there is no tomorrow for you. You are all in the preparation leave. So last 10 days onwards, you are at home. So this is every minute matters. So without wasting anything, we will start. And first and foremost, I would like to tell you, let this day go. I will study seriously from tomorrow. That kind of attitude do not develop. Let this day go. I will study seriously from tomorrow. There is nothing tomorrow. Everything is today. So let's begin now. Next 1.5 hours, that is till 9:30, the session will be there. After that, if required, it may go a little further also. Right. So I will be discussing the 10 questions which I have already given. And after this question, I will be discussing the local anesthesia advances, which was a main question. Right. Because the local anesthesia advances are based on gate control theory. So this gate control theory, if you understand, everything becomes easy. Okay. So the name itself is gate control theory. So there is definitely a gate and someone is controlling it. Right. So the name itself tells that. And this is a 5 marks question. It has come in your exams a lot of times. Please understand that this is 5 marks question. What is this gate control theory? Just look at this diagram or the photograph. Now, if you see here, there are 2 trains. One is happy train and another one is pain train or sorrow train. Both the trains are stationed or next to each other and the brain is there. The brain is the railway station. And then you see a gate man. So this gate man is the one who will decide one train to go first. Either the happy train can go or the pain train can go. Both the trains cannot reach the brain at the same time or the station at the same time. So who is controlling that? Someone in the gate is controlling that. The way he controls, the pain or the happy train reaches the brain first. So put this concept in the mind. After 5 minutes, towards the end of gate control theory, I will tell you to recollect the same diagram. So the same diagram, same photograph, we will reach after 5 minutes. So please take a photographic image in your mind. Okay. So first and foremost, who gave this theory? Gate control theory. This was given by 2 people. One is Melzack, another one is Wall. Ronald Melzack and Patrick Wall in 1965. Right. So this is basically a psychological mechanism. This gate control theory is a psychological mechanism by which psychological factors affects the experience of pain. So it's a psychology. Right. So if the psychology is correct, everything is fine. For example, you lost your mobile phone in the morning. You're crying. evening you get some 10 lakhs rupees from somewhere. So you become happy. Right. So same day, morning you were crying for the loss of something, evening you got something else, so you are happy. So it's all the psychology which matters. Same way, same results came coming for two people. One student is taken positively, if suppose if it's a fail, one student taken very positively and studying very hard for the next exam, another person goes into depression. So same result, same impact, but two different responses. So it's all based on the psychology. So this gate control theory is also based on psychology. So we have a gate man, we have seen that. So there is a neural gate which can open and close. So there is a neural gate, I repeat, which can open and close. So based on that, the pain will reach the brain. So now the gate man was there, right? So where is this gate man? The gate man or the gates are located in the spinal cord. Question number one, where it is? It is in the spinal cord. Gate man, who will take the command? Okay, pain, you go, or happy response, you go. You reach the brain first. One of them only will reach first. Both cannot. You cannot be happy and crying at the same time. So this gate man has four functions. One, it will allow the information to directly pass to the brain. Directly pass to the brain. For example, your college principal is there. Two people are studying in the library, talking and so much. So the librarian will go and tell the PA, the personal assistant of principal, lot of nuisance is there in the library. So the PA to the principal can directly pass the information to the principal by telling that, sir, lot of nuisance is being created. That is first option, directly pass the information. Second option, the information is altered prior to being forwarded to the brain. Information is altered. So that means the librarian has told the PA to the principal. The PA to the principal has added more information. Sir, they are not at all talking, but they are singing, dancing, they are doing all those things. So he has supra added his own version and magnified the problem. So one alteration is increasing the intensity. Or the PA up to the principal can reduce the intensity of the information. Yes, sir, the librarian came, but it was just a casual, they were talking, so he just told like that. I think he can take care of that. He just removed the intensity and but still inform the brain also, or the principal also. So it can increase or decrease, or it can directly allow to pass to the brain. And the fourth function of the gate is it can prevent it also. So the PA to principal will tell, okay, no need to tell principal, unnecessarily he will take action against them directly, we will only deal it. So the information is stopped reaching the brain. So there is no pain. So these gates are in the spinal cord, and spinal cord, where we go back in detail again. So here the gate man has got four functions. Directly allow the information to go to the brain, stop the information to go to the brain, increase or decrease the intensity of the pain. So before going into details, please remember a mnemonic called SAME, S-A-M-E. So S for sensory, A for afferent, M for motor, E for efferent. SAME. So what I am trying to tell you is the sensory information, the information which goes towards the brain, that is sensory nerve, that are called as afferent nerves. The other name for sensory is afferent. And the motor, the information which comes from the brain and goes to the organ is called motor, or also called as efferent nerve. So sensory are afferent, motor are efferent. Okay. So now the pain pathway, which you would have studied in first year physiology also, same thing is here. So first and foremost, the receptors will be there in your body. They are called as nociceptors. So once a pain stimulus is sensed, it will take the information towards the brain. Who will carry towards the brain? The sensory nerve. So afferent fibers. So afferent fibers will take the information and then it will go to the gate. The gate is in the spinal cord. So this is the spinal cord, what you're seeing, the flow chart I'm talking about. In the spinal cord, there is ventral and dorsal horns. Its spinal cord is like a butterfly shape. So dorsal and ventral part. In the dorsal part, substantia gelatinosa is there. So this is the exact place where the gate man sits. Where he sits in substantia gelatinosa. And from here, the information is catched and it's given to the brain. So your viva question can be substantia gelatinosa also. I'll come back to that again. So this is the pathway what you need to learn. Now, so what does this gate control theory says? So gate control theory says the presence of injury. It is taking information towards the brain. So now there are two types of fibers: small peripheral fibers and large peripheral fibers. Small fibers, large fibers. Presence of injury is told by small peripheral nerves, and they will take the information towards the brain. And the large peripheral fibers, what they do, they tell about temperature and pressure. So two types of fibers: small peripheral, large peripheral. Small one tells there is an injury, and the large one tells temperature and pressure. Now, once they reach to the brain, then the descending control system, there is ascending and then there is descending. The descending control system originating in the brain is modulated, or it modulates the excitability of the cells that transmit information about injury. So information goes towards the brain. The brain will process it and then tell, okay, it's the injury insult is too much, so there should be pain more. The descending control system is regulated, so you don't feel pain much. So this is the main concept what we are going to learn this now. Please write this in your notepad. Extremely important. So I told you there are two types of fibers: small peripheral fibers and large peripheral fibers, or nerves you can call it. The small peripheral nerves tells injury. Who are they? A delta and C fibers. Not to miss this keywords. A delta and C fibers. And then you have got large peripheral nerves, which is A beta fibers, which will tell pressure and temperature. So the action is there: small, large. One is injury, one is temperature and pressure. A delta and C fibers have the same function. A beta fibers is the large peripheral nerves. So I hope you understood this. Do not get confused, because A delta, A beta, some confusions can come. Okay. So presence of injury, A delta and C fibers, which is small peripheral nerves. Now this is an example what I am telling about. So you have a finger. Imagine someone hits with a hammer. So someone hits with a hammer. Someone is hit one time, it has been hit with a hammer. So what you do, it starts paining, right? So you rub that finger. Yes or not? You rub your finger. Or suddenly you're walking something, or you go and bang the door. You rub that area. Similarly, in cricket matches, you see, or football matches, you see, when the player falls down because of an impact of the ball hitting, the physiotherapist will come and he will rub that area. So that is what we are going to get into. So there is an injury, what we saw here, and then after that injury, rubbing the injured finger. So that is what the next step is. So this is what gate control theory we are going into. So we are rubbing the finger. So this is what very, very important. So that's why when someone hits or you get a hit, you rub, automatic reflexes. So presence of injury is A delta and C fibers. Presence of injury. These are small peripheral nerves. And your temperature, pressure, and large peripheral nerves is A beta fibers. So both are different, okay? Presence of injury and your temperature and pressure by A beta fibers. Yes. So same thing. There is a painful stimulus. Hammer hit the thumb. So A delta and C fibers carry information towards the brain. Correct? So you see this, the green color it is shown. It goes here, it goes here, it comes till here. Similarly, you start rubbing the finger. That is your A beta fibers get excited. They come like this, come this blue line, and they also come here. So this is the railway station. This box, what you are seeing is the railway station. And this green color fibers and this blue one, these are the two different trains. One is A delta and C fibers, which is presence of injury, small peripheral nerves, and the other one is A beta, which is because of the deep touch you have done, you have rubbed that area, the pressure you have created. So because of that, A beta fibers got excited and they both reached here. Now both of them at a single place. Where is the gate? Gate is in the spinal cord. This is the spinal cord. In the spinal cord, substantia gelatinosa is here. Now the whole story begins from here. Yes. Now you see this. A beta fibers have come, C fibers have come. Both came at a single point. Now here, substantia gelatinosa is the railway station. Railway station. Either I should take the happy train or the pain train. Only one can do. One can reach. Please understand the major logic here. Major logic, please see here. You have got A beta fibers. A beta fibers is by rubbing, pressure, temperature. Okay. So this A beta fibers, they come here and it has two arms. You can see here, one arm going like this, another arm going up. So with one arm, suppose someone is running from my backside, I try to block it with my hand. I try to block them, the other person. So the A beta fibers will come, give an extension, and this A delta and C fibers, that is the presence of injury which is coming here, that is being blocked by the one wing of or one arm of A beta fiber. So the presence of injury is going, I am telling stop. So my right hand has stopped that person. At the same time, the other branch has reached the brain. So it is just like someone is running, you stop that person and the other person is given the signal to reach the brain. So what reaches the brain? This pain, A delta and C fiber is pain. Pain is not reaching because it is stopped here. Whereas the counter massage, what is being done, that reaches the brain first. So you don't feel much pain. So whenever you get injury, you get hurt, start rubbing that area. Okay. So that pain fibers does not reach the brain and your counter stimulation reaches the brain first. You activate the gate control theory. So I hope you understood the concept here. So everything, the whole game, the whole magic is here. Same thing, this diagram I have taken from your Monim's book. Those are reading Monim's. This photograph is there. So same thing I'm trying to explain. So whenever there is an injury, your A delta and C fibers gets excited. And you start stimulating fast fibers or peripheral fibers, A beta fibers get excited. So this fast fibers, A beta fibers travel more faster. They bypass. It's like without entering the city, it is bypassing and it reaches the brain. Whereas small peripheral fibers is stopped here. By the another hand, A beta fibers, one hand goes up, another hand is going in blocking. I'm just trying to tell you in a very simple manner so that you will learn it and you can reproduce this in your exams. Little bit of reading, one reading will solve this problem of this gate control theory. So now, factors which open and close the gate. Now, amount of activity in the pain fibers. If the stimulus is more, gates will open. So you will feel the pain. Amount of activity in other peripheral fibers also determine and message that descends from the brain. So these three factors are there which will tell whether the pain stimulus will reach the brain or not. How much is the intensity? If intensity is less, it will not reach the brain. Intensity is very big, it will reach the brain. And activity in other peripheral fibers. Other peripheral fibers, if you are again rubbing that area, if the activity is more, again pain will be, the pain fibers will be taken into sight and then the counter stimulation will reach the brain first, which I have told you in the diagram. And the information which comes from the brain, descending control system, is also blocked. So conditions that open the gate, physical condition, extent of injury, emotional condition, you always sit on taking tensions, exams are there, tension, you're taking worry. So that will give you more pain. Mental condition, focusing on pain, always thinking about pain and boredom, that opens the gate and then there is pain. Similarly, the conditions that close the gate, physical conditions like medications, you have pain, You take medication, you counter stimulate that, you take heat steam, or you massage your what you say counter stimulate massage, or you apply what you call it Vicks and all if you are having cold and all, right? Or some balms you apply, you get relief. That is counter stimulation. Emotional condition, you take rest, right? Relaxation, you feel better. And distraction, you get distracted from that particular area, you don't remember that area, you feel better. So these are the conditions which close the gate. So factors which open the gate, which close the gate. Where is this gate? Spinal cord, substantia gelatinosa. Right. So this is one MCQ. This can be used like a viva also, which always comes in the viva. Gate control theory of the pain is due to. So I have taught you this right now. It's very easy to answer. It is substantia gelatinosa. Right. So right now you're having exams. So exam preparations before the start of the year, you all will be something like this. Right. And exams without anxiety, it is extremely difficult. And I am very sure many of you will be in a condition like this by the end of preparation. So dear students, the second photograph image should not happen. This is because of lack of planning, lack of active, what you say, timetable, and lack of execution. Right. You're not doing correct things at the correct time. So that is why the second photograph comes. So that should not be happening. Still 10 more days is there for you. So do correct things at the correct time, which I will be discussing over the course of time today itself. Okay, so don't think that you are in a boiling pot. Never. This situation, please remember, everyone goes through. Even I, when I was a student, I also went to with the same feeling what you are going through. So this is part and parcel of everyone's life. You may prepare one subject, you may get tension for the other subject. When you're reading second subject, third subject, you may get tension. Don't worry. This is part and parcel. Make sure all the past year questions are done. All the question banks you have done it. And from the textbooks, all the diagrams you have practiced. Art of presenting answers, I will be discussing again. Now coming to the last year main question, recent advances in local anesthesia. So I would like to thank my student Lakshmi Sayuja for giving me photographs and few slides for this. Recent advances in local anesthesia. Okay. So now this was the main question, and it was really like what you say, bouncer for the students who were there in the last year, because except one or two things, they don't study much, and it was the main question. So let's begin this. So dear students, please understand that there are 8 advances in local anesthesia. There are many more, but these 8 are tried, tested, and it is there in the market also. Out of this, 2 you will be knowing very well. That is EMLA, E-M-L-A, EMLA, and computer controlled local anesthetic devices. Many of you would be knowing that. So 2 you are very much aware. Other 6 also I will inform you. So first and foremost is, so please write it down, okay? The first advances in local anesthesia is AccuPal. So you can see an instrument over there, right? So there is a battery type like that. So whichever area you are going to give injection, put in that area and switch on. So there will be a lot of oscillations and vibrations will be there. So basically it is a cordless handheld. You can hold it with the hand, right? So what happens? Once the oscillation takes place, it inhibits pain by preconditioning the injection site. So that site, it's preconditioned. A lot of vibrations are created over there. So our gate control theory, what it was, if there is hit, you rub that area, right? You rub that area. So here, before the pain comes, we are rubbing that area. Oscillations and vibrations are created. So AccuPal integrates the pain gate theory in order to energize the dental tissue and around the needle insertion site. So in an area, all the peripheral nerves, all the vibrations it will take, and it will reach the brain first. So only the oscillations and the vibrations the patient will be feeling. After that, you give a normal traditional injection. nothing will happen. The patient will not have any pain. So this is the newest trends in local anesthesia. Number one, this is called acupulse. Second one is called dental vibe. Dental vibe. Right. So you can see that instrument over there. So it is just more or like the previous one, acupulse only. It's also a cordless, handheld, and rechargeable device. So it's a battery driven and rechargeable device. So once you put there, it also, when the battery is on, switch on, micro oscillations are there. It will be very soothing, pulsating, and percussions will be there, right? Percussive to the injection site. So that area, there will be soothing effect, a pulsating effect, and percussions will be there. So again, after doing this, your gate control theory gets activated because activity took place there. And then when you give the injection, there is no pain at all. So this is one more variety or one more trend in local anesthesia advances, dental vibe. Third one is safety dental syringes. So you can see the diagram, a normal cartridge type, but it's more safety precautions are taken. So wherever, see the needle is here. Next to the needle, a protective sheet is also there to prevent needle stick injuries. You always hit here, there, patient moves, so needle stick injuries can happen. So always a barrel shape, a protection will be there around the needle. Only part which has to be exposed will be exposed. So these are called safety dental syringes, and various types are there. Ultra safe type, ultra safe syringe, XL, hypo safety, RecVac safety. All the names are enough. So this is the third one. Acupulse is the first, dental vibe is the second, third one is safety dental syringes. Now the fourth one, which you are almost, or I feel every one of you are aware of, it is there in your textbook also, that is called an EMLA, E-M-L-A. It's a cream. So once you apply the cream, that area, anesthesia will be there. And then when you give the injection, there is no pain. So this cream is a mixture of euthetic mixture. So what do you mean by euthetic mixture? Euthetic mixture means two components equal weight. So E, euthetic mixture of local anesthetics. That is the short form, EAMLA. So you have got two different types of local anesthetics here, lignocaine and prilocaine. So lignocaine 1% by weight, prilocaine also 1% by weight. So this is applied prior, right? Basically 1 hour, half an hour to 1 hour prior the surgery, you apply that area. And then after that, when you apply or give injections, there is no pain at all. So it is widely used in children because children have a lot of phobia for the syringes. So this is the fourth advances. Fifth one, which you all should be aware, and this comes as 3 marks question also. This is also called as CCLAD. CCLAD. Computer Controlled Local Anesthetic Device. CCLAD. So you see this the photograph here. It's like a small machine here, right? Some buttons are there, and then you see here you have a small pipe over there. This is like your, what you say, when you take saline and all, the drip set is there, right? So it's just like your drip set, and it is attached to a small needle. And then there will be a footrest, like aerotel micromotor, you have a pedals, right? Like that, footrest will be there, the pedal will be there. So same way, when you put the pedal, and now here switches are there, you can prefix it. It is for inferior alveolar nerve, it is for PSA, it is for infiltration. Basically, it is used for infiltration purpose. So once you switch that button, only that much amount of LA only will be injected. Extra mLs will not come. And you can press the pedal, go insert it, press the pedal, and the beep sound will come once it is done. So that is very effective, and there is no pain. It is just like insulin thickness syringes. So very, very small thing. So the patient will have no sensation, no feeling for that injection. But because it is computer, the machine is there pre-programmed. So it is why it is called computer controlled local anesthetic device, CCLAD. It's highly effective and better than the traditional syringes, and it controls the speed also of the injection. Some people, generally injection needs to be given 45 seconds to 1 minute, but some people give very fast. So here, even the speed, the rapidity of injection is also controlled. So this is the fifth advances. Next one is compu flu. So computer flow, FLOW flow, flu they have taken from there. So this is again one advance. It permits immediate and real-time measurement of fluid exit pressure at the needle tip. So you have got needle tip. What is the pressure with which the solution is going inside? That will be what you say audited here and reflected in the screen. So this method of measuring fluid exit at the pressure at the tip of the needle is referred to as dynamic pressure sensing technology. So that is also controlled because our major complications of LA is because of the speed at which what we are giving and the extra amount of solutions what we are giving. So both of them are CCLADs and CompuFlu will take care of that. So this is all latest advances. You don't have to explain this in detail, how it happens, why it works. That is the company, manufacturers, how they have made it. That is the manufacturing manual. As a BDS level in the exam, it's part of the main question. Basic things, if you know, that is more than enough. Next one is Stabident. It's again, it is a device used for intraosseous anesthesia. So bone and all also you can inject. But the disadvantage is it is inaccessible areas, you cannot use this Stabident. So basically it is for intraosseous anesthesia. Then you have got VibraJet, the last one of that, VibraJet. So again, you can see the photograph here, VibraJet. So it's a vibrating dental local anesthetic attachment. You can see here one attachment is here. So that is the VibraJet. Right. So that uses gate control principle as its foundation. So all the advances in the local anesthesia devices is using gate control theory. That's why I kept gate control theory first. What is gate control theory? I explained you. A, delta, and C fibers are the small peripheral nerves which detects pain, injury. And A, beta fibers are the ones pressure and temperature. A beta fibers will block A delta and C fibers and it will reach the brain first. That is gate control theory. So again, these are battery controlled and external attachment will be there. So vibrations will be created that are sensed by the patient. Once you are going to give injection, first the vibrations will be created. And when the patient is feeling that vibration and then the injection is given. So there is no pain during injection. So this is called as VibraJet. That is a combination of gate control theory plus your traditional local anesthesia. So that is all about the main question which has come in your examination, right? So a big chunk of local anesthesia we have covered. Normal traditional blocks and all you can read yourself, which you have been doing it from third year BDS onwards, right? So we have done one main question and a very, very important gate control theory, which people find it little difficult to understand. Next, coming to a 5 marks question, which is emergency drugs in dental practice. Emergency drugs, very, very important. It comes as 5 marks and students always find difficult to write this answer, right? So there are a lot of emergency drugs, atropine, diclofenac sodium, dexamethasone, morphine, glucose, sublingual nitrate. There are some more adrenaline injections, derifylline, dextrose, ranitidine, diazepam, tramadol. So you should know at least some 8 to 10 names. I'm talking theory point of view. Practically, these are very important. No clinic can run without these medications. Whenever there is an inspection, they try to check all these emergency drugs only. So without this drugs being updated, there is no inspection. The licensing only will not be given. And you should be well aware to give IM and IV injections. You know it is IM, but you have never given IM, very bad. So that needs to be really, really taken into account. So some of the conditions today, what we will be discussing is syncope, angina pectoris, myocardial infarction, epigastric pain, hyperventilation, coma, bleeding, and some more. So all the flowchart manner. I'm not going to talk any theory here. Everything will be flowchart. If not this, then that, like that. Then adrenal crisis, thyroid crisis, so all those things, emergencies. It's almost like some 14 emergencies we are going to discuss now. So first and foremost, syncope. So you know that the extraction, whenever the extraction is going on, patient went into syncope. So we do extractions in anti-Trendelenburg. Keep the patient flat. The heart level should be above the brain level. So that is Trendelenburg position. So keep the patient flat. That is for syncope. Right. And if the patient is supposed in a chair, make him lie down on the floor. Always make him lie flat. Keep the legs elevated. Now, patient is going to syncope. He went to syncope and he again woke up. So that little haziness is there. Patient is conscious. So if the patient is conscious, then give spirit of ammonia, glucose powder. You can give that. Patient will be fine. But the patient is completely in comatose position. He is unconscious. Then you have to give IV dextrose 25%. Please understand, this is a gold standard drug. Whenever a patient goes into syncope, first step is he is not waking up. IV dextrose 25% you have to give. Right? So IV, intravenous lines, you have to find out and you have to give that. So patient will be fine. So conscious, you will give glucose. Unconscious, IV dextrose you will give, patient will be fine. Next condition, angina pectoris. There is chest pain. You're taking a case history and suddenly patient develops a chest pain. You're just given an infiltration or a block, patient develops chest pain. So first and foremost, stop the procedure. You need to have sublingual nitrate tablet. The sublingual nitrate tablet, you will take it, put it below the patient's tongue. One tablet, put it below the tongue, wait for 5 minutes. Not getting relief, again one more tablet. Not getting relief, again one more. Maximum 3 times you can put. Right? But at the same time, if not getting relief on the very first time, activate emergency and call the doctors or ambulance, and you need to make sure the patient has to be transported also. But if by giving sublingual nitrate tablet, pain is relieved, very good. So that is angina pectoris. Stop the procedure. Now there is no pain. Initially he had pain. You gave sublingual nitrate. Pain is relieved. Patient is telling, I am fine, sir. Don't proceed with the extraction. Stop it. Refer to a cardiologist and then postpone the extraction. Even after giving sublingual nitrate tablet, pain is not relieved. Then it is not an angina pectoris. It could be any of these 3 conditions. It could be myocardial infarction, it could be aortic aneurysm, or it could be gastric pain also. So I hope you're understanding. It's very clear. Sublingual nitrate tablet, pain relieved, angina pectoris. Not relieved, it could be myocardial infarction, aortic aneurysm, or gastric pain. It's a gas problem. Because of gas problem, chest pain came. Right. So myocardial infarction, there is pain across the chest, the patient starts sweating, and pain in the left arm radiating from the heart to the left arm. You gave sublingual nitrate tablet, not getting relieved. So what you have to do? Don't move the patient. Like you just make the patient stationary and activate the ambulance and all, doctors and all, that is secondary. Don't move the patient. Give the physician call the doctor, start giving oxygen and inject morphine 5 mg slow IV. So this is your immediate treatment, right? Myocardial infarction, start giving morphine, shift to hospital as soon as possible. Then don't move the patient, give oxygen. So angina pectoris, pain not relieved, first possibility, myocardial infarction, you have to do this. Second one, epigastric pain. So patient is having lot of gastric pain and that is radiating to the chest and you're giving sublingual nitrate tablet, it's not getting solved. So this is the area where the lot of pain will be there. Epigastric region. You see here, there is pelvic region, then you have got umbilical region. This is your epigastric region. below the chest. Here, lot of pain will be there. So if there is epigastric gastritis, what do? Your elders will be taking Rantac. Same way, ranitidine injection IV has to be given. So all the epigastric pain will reduce. Eventually, the chest pain also will reduce here. So drug of choice, epigastric pain, ranitidine injection IV. Next condition, and then other one is aortic aneurysm. So that has to be referred to a physician, doctor, and it has to be dealt in a big setup only. In dental clinics, you may not be, and you cannot deal with that. Next condition, hyperventilation. You are trying to do an extraction or a case, and suddenly the patient is telling, sir, I am feeling shortness of breath. I cannot breathe. There is oxygen, there is everything, fan is on, everything is on, AC is on, but the patient is not getting the air. So give carbon dioxide, not oxygen. Please understand that. So how you can give carbon dioxide? You can take a plastic bag, put it in front of the patient, let the patient blow the air. So carbon dioxide goes inside the plastic bag, and the same carbon dioxide patient will inhale also. So that will help a lot. And the other option is you can make a funnel with the paper and keep it there. So whatever exhale can be inhaled also. So a good amount of carbon dioxide will go. Next condition, diabetic coma. Diabetic coma. So a patient is having diabetes, he collapsed. So you don't know whether the patient is hyperglycemic or hypoglycemic. You don't know. You just know his diabetes. Patient collapsed. If you don't know, no problem. Whether it is hyperglycemic or hypoglycemic, whatever it is, we don't know. Just give IV dextrose 25%. This is the same IV dextrose which we gave for Syncope. You remember Syncope? Comatose patient, same thing here. Because patient is in the coma or he collapsed, we gave IV dextrose 25% injection. Fine. Now what happens? Either the patient will wake up or the patient will be still unconscious. So you gave dextrose IV 25%. If the patient recovers, then that is hypoglycemic coma because the dextrose sugar level was down, hypoglycemic. Because of hypoglycemia, the patient collapsed. So it is hypoglycemia or hypoglycemic coma. And if necessary, give glucagon injections. Even after giving dextrose 25%, patient does not recover, then that is hyperglycemic coma. Already it is more. And if required, give insulin injection. So it's so simple. A patient collapsed, you don't know if it is hypo or hyper. Just give IV dextrose. If the patient recovers, wakes up. If required, give glucagon. If the patient does not recover, give insulin. So without patient telling anything, you know to give either glucagon or insulin. So this flow chart will really help you all. Next condition, bleeding. If there is massive bleeding, right? So first and foremost, see the problem. See if any arteries are cut or what. Then you should, if there is a bleeding from the bone, what you can do is your ball burnisher. In conservative, you'll have, right, ball burnisher. You can heat that ball burnisher, go inside the socket and rub that area. So the bleeding will stop. 90% of the time, bleeding will stop. Then you have other hemostatic agents also. You can give ethamsulate injections, Surgicel, gel form, vitamin K, gel form. I think you know all these things. You can cut small piece of the gel form, keep inside the socket, and then tight sutures you need to give. So this is ethamsulate injection is also given there. Next condition, adrenal crisis. Suppose your department is in second floor, third floor. You are going by steps. One of your friend is not able to walk properly. Once the person comes up to the floor, he is completely tired, whereas you are absolutely okay with climbing the steps. So this is because of the stress level, change in stress level. So if a patient is taking steroids, it's very important, okay? So you should always take the previous history. If the patient is taking steroids, whatever mg patient is taking, just before the extraction, double the dose. just before the extraction, okay, not 1 day before, half day before, 1 week before, no, just before the procedure, you can double the dose. So suppose the patient is taking 100 mg, 100 mg is for his normal survival, and another 100 mg which you're doubling it, that is for the stress what will be imparted because of the extraction. So this is just before the procedure. Next, thyroid crisis. So patient, we give anesthesia, and suppose patient is telling, sir, I'm having thyroid problem. So this patient may have palpitations and tremors. So even the heart will be beating very fast. A tachycardia will come. So heart will go for a 6 means tachycardia will come. So avoid adrenaline in local anesthesia here. So patient with thyroid problems, don't give adrenaline. And simultaneously, chlorpromazine, carbimazole, and dexamethasone should be ready. And if the thyroid crisis has happened, this should be injected. Take a screenshots. It will be very, very helpful for you. Right? It is very short and concise. You can just go and write in a very short period of time. You can fill your answers. Cardiac arrest, next condition. So you know in the cardiac arrest there is no pulse, no respiration, no heartbeat. Right? The patient is completely null. Nothing is happening over there. Then start CPR immediately. Head tilt position, right? And then chin lift, jaw thrust you will do. These are the two basic things what you know that. And then the intermammillary lines you will try to connect, and just at the center on the left side, you make a fist and give compressions, right? Like the Zippite process, you will give compressions. And for these conditions of cardiac arrest, you can give adrenaline injections 1:1000 or 0.5 ml subcutaneous injection, or hydrocortisone injection 100 mg IV also can be given. So simultaneously you have to start CPR as well as this medicines also needs to be started, adrenaline, hydrocortisone. Apart from that, sodium bicarbonate should be started, ECG monitoring, the PQR intervals, everything you need to study, oxygen should be given, and medical help also needs to be done. Okay. Next is if the patient has aspirated something. If there is a foreign body aspiration, right? So if something has gone inside, so definitely it's a foreign particle which is the problem. So you have to take it out. No medicines are there to take the foreign particle out. So no drugs, only action. And what is that action? That is called Helmig's maneuver. So bend the patient like this, back of the patient, give 5 blows, and then in the epigastric region, interlock your thumb and just compress that area. 5 abdominal thrust you have to give, and the choking thing, 99% it will come out from there. Next, in case of epilepsy, if a patient is having epileptic attack during the procedure, just stop the procedure and protect the patient from hurting himself. Whatever instruments are there, take it out. If the procedure is going on, you have a bite block, put the bite block so the patient does not bite his tongue. If nothing is there, put a cloth, some cloth material, handkerchief, patient's handkerchief, anything, just put it here so that patient does not bite. And start suction. To calm the patient, give diazepam, 2 to 5 mg. IV, you can give the diazepam for epileptic patients. Patient, next condition, asthma. Patient is having asthma. So in asthmatic patients, please understand that patient should not be made to lie down. Patient should be in sitting position. Generally, anything happens, we tell the patient to lie down. Asthmatic patients not lying down, they should be in sitting position. Then the drugs, derifylline, hydrocortisone, salbutamol, inhaler has to be given. Right? So these are the things, this is how you have to present the answers. In case of allergy or anaphylactic reaction has happened, you gave an LA and suddenly anaphylactic reaction happening, hydrocortisone, ephedrine, and chlorpheniramine maleate injection. So 3 options are there to counter the anaphylactic reaction. So hydrocortisone injection, you should know very well. So you should, even the spotters, these are useful. This question what I am discussing for your spotters also, it's very easy. Next is bradycardia. If the heartbeat is coming down, elderly patients, heartbeat is coming down, and heart rate is less than 40, then atropine injections can be given. And if required, directly intracardiac injection can also be given. Directly intracardiac injections can also be given, atropine injections. Now, patient has severe post-operative pain. An extraction, impaction was done, and he is unbearable, having unbearable pain. So basically, what you are giving non-steroidal anti-inflammatory drugs. So now you give the other version, that is the opioid analgesics. So you can give tramadol injections, or tramadol tablets are also available, right? Diclofenac sodium injections. This if it is given IV, what happens? Instant relief will be there for the patient. That you know that IV, no first pass metabolism, and parenteral route of drugs are fast acting. Right. So know the best time of the day to study. Right. So this is, you're having only 10 days for the exam. So there is, every time is the best time for you. But a general study was done, and it was told that the best time of the day to study is from morning 4 a.m. to 9 a.m. So this is the best time. Early morning, 4 a.m. to 9 a.m. is the best time of the day to study. The second best time is evening 7 to 10 p.m. Mind is very alert. So what you have to do is, now you have got 4 subjects. So you know your best time, worst time. So if you're reading all the 4 subjects on a daily basis, at least till last 4 or 5 days before the exam, in your best time, read the most difficult subject, so that you will read with more concentration. Then in your worst time, where you are not at all active, read the most easiest subject of the 4. So that way what will happen? Your productivity will come up. But when you're very active and you're reading the easy subject, the easy subject you will master, but the tough ones you will forget it. You will have no interest in reading that. So that is the takeaway information, what you need to do in the next 10 days by this timing solutions. Next question, ASA classification of patients. So this is from general anesthesia chapter. Again, it's a very important question. It comes 3 marks also. So this ASA classification, ASA 1, 2, 3, 4, 5, 6 are there. So this I will try to give an example and relate it with the BDS students. ASA 1 is like first BDS student who are very young, energetic, very happy soul, and very, very interested in everything. A normal, healthy patient, first BDS students. The first BDS exams over, in second year they go, they become ASA 2. ASA 2, second BDS student. So they had biochemistry exams, physiology, dental histology. So now they have tasted. So second BDS are ASA 2, a patient with mild systemic disease. Mild disease. So mildly they have tasted it, and now they understood what is dentistry. Very little dose is given. Then ASA 3 is the third BDS student, the honeymoon year. They are always in the department. They are in the department. HOD will see them, staff will see them, but they will not tell them anything, because the whole concentration is towards the final year students. So ASA 3 is a patient with severe systemic disease, which is not incapacitating, not life-threatening. No problem. That is third BDS student. ASA 4 is the final year students, like you. A patient with severe systemic disease, which is constant threat to life. So if you don't do your cases, you take any unwanted leave, you're always in trouble. So constant threat to life. ASA 5 is the house surgeons. A moribund patient who is not expected to survive without operation. They will not get up. They will always sit in the OP table, their chairs, and just in the mobile phones. You have to shout, scream, and then only they will get activated. Then ASA 6 are the students who are preparing for PG. This is just a mnemonic, okay? Just a way to relate, I am telling you. A declared brain dead patient whose organs are being removed for donor, preparing for PG, or PG students of your college. They always get left and right from their departments, right? So a declared brain dead patient. So this is how first BDS, second, third, fourth BDS, what you have. ASA 1, 2, 3, 4, 5, 6. We can recollect like that. So if you correlate, you will never go wrong in your exams. So ASA 1, healthy patient. ASA 2, something like this, mild systemic disease. ASA 3, not incapacitating but serious systemic disease. ASA 4 are the final year students, all of you right now. And PG students and the postgraduates are declared brain dead patients. Right, so we are into the next question. Right, HBO therapy. Very, very important question. So hyperbaric oxygen therapy is a treatment given for two conditions, osteomyelitis and osteoradionecrosis. A bone which is completely infected, pus is draining out, then you need to do something extra. So there is a chamber called as HBO chamber. So this is what is HBO chamber, a special room, right? So where the patient will be inside the room. You can see here the patients are all sitting. They're all dressed up and they are sitting here. The doors are closed and then there is an operator outside. And he have lot of controls are there. It's just like a space shuttle, right? So then he will control few aspects which I'm going to talk right now, and the patient will inhale oxygen. Right. So in hyperbaric oxygen therapy, this is 5 marks question, okay? And this is a solution or the treatment management of osteoradionecrosis, which is the main question. So here inhalation of 100% oxygen, when the patient is taking oxygen, 100% oxygen greater than 1 atmospheric pressure. So normal atmospheric pressure, you and me, right now it is 1. Inside the room, it will be greater than 1, that is 2.4 atmospheric pressure. The patient will be taking 100% oxygen at 2.4 atmospheric pressure for 90 minutes. So these 3 parameters you should write: 100% oxygen, 2.4 atmospheric pressure, 90 minutes. So this is called one dive, DIVE. This is the unit. So the treatment is given for 5 days per week. Either they are given 30 dives, 60 dives, like that. Okay. So one dive is equal to 100% oxygen, 2.4 atmospheric pressure for 90 minutes is one dive. Right. So this is what it's a viva question. So when the patient is taking 100% oxygen, what happens? A tsunami of oxygen goes inside. The tissue oxygen tension, 100% oxygen, right? The tissue 100 oxygen tension, which was 10 to 15 initially, it just shoots up to 150 to 250 mm of Hg. Where is 10 to 15 and where is 150 to 250? A drastic exponential rise of influx of oxygen takes place. So this oxygen shoots up and again it comes down. Then oxygen shoots up and then again it comes down. So this is like a tsunami of oxygen is coming up. So what will happen? It's just like a spark is given. So this spark will stimulate the fibroblast collagen production. Fibroblast collagen production, and new blood vessels will be formed. So new angiogenesis and new cellularity and new vascularity will also start because of intermittent increase in oxygen level. So increase in arterial and venous oxygen tension also happens, and it will have a direct bacteriostatic effect on the microorganisms. So whatever microorganisms were there, the problem is on the bone, osteoradionecrosis. A lot of bacteria were there and they were eating the bone, right? So all those areas, suddenly life will come in the bone and all the bacteria will also die up. So there will be new angiogenesis, fibroblastic proliferation, and collagen synthesis will occur. These 3 things will happen because of sudden influx of oxygen. So this is what new blood vessels, new cellularity, new angiogenesis will take place. So now the treatment of osteoradionecrosis, there is something called as Mark's protocol. Only Mark's protocol can come as 3 marks. So now patient is diagnosed with osteoradionecrosis and he comes to HBO chamber. So for the treatment. So now once the patient is diagnosed and the doctor has recommended, he needs to be given what you say, the hyperbaric oxygen therapy. So the initial level is called stage 1. Now, whenever we go for a marriage, generally in marriage functions, what is there initially? The welcome drink. So here also, in every stage, the welcome drink is 30 dives, 30 dives. And then in each stage, maximum of 60 dives can be given. This is the rule. In each stage, welcome drink is 30 and maximum up to 60. So another 30 more you can give after that. 30 plus 30, 60. That's all. So stage 1, welcome, 30 dives are given. So after this 30 dives are given, patient is again re-evaluated. They check that area. If healing is taking place, okay, very good. In each stage, your quota is 60. Only 30 we gave and your healing started. You take your remaining 30 and your treatment is permanently closed. You gave 30 dives, patient went home, again he came back after a few days and it's not healing. Not healing, okay, no problem. You will be promoted to stage 2. But in stage 1, maximum you should get is 60 dives. Only 30 we have given like the welcome drink. You take remaining 30. So if no improvement, the patient progresses to stage 2, but after making the 60 dives. So stage 1, 60 over. Now, patient comes to stage 2. So initially, again, welcome drink, 30 dives are given. After that, sequestectomy and primary closure. All the dead bones, you will try to take it out. Dead bone, sequestrum. Involucrum, living bone. And living bone surrounding the dead bone, like an island, that is involucrum. Sequestrum, dead bone. So all the dead bones, take it out with the burr, cut it out, take it out, induce fresh bleeding, and do a primary closure. When you will do after initial 30 dives. Send the patient. After few days, he comes back. Then you check. Healing is taking place. Very, very good. Okay. So you take your 30 more. Your stage 2 treatment is over. Your total treatment is over because it's healing. After sequestectomy, primary closure, patient went back, 30 dives he took before, he did all this procedure, he comes back, it's not healing, second condition. Okay, not healing, you take your remaining 30 dives more, come to stage 3. Every stage, 60 dives has to be made. So stage 3, again, welcome drink, 30 dives you take, and the area which was dead, even after inducing fresh bleeding, sequestectomy and primary closure, it was not healing. You resect that area. You cut that area and throw it out. That's all. That area is sacrificed. Cut it and resect to the bleeding. And then give 30 more dives to the patient. End of stage 3. Now, because you have resected that part, so you have to do the reconstruction also. That is called stage 3R. So what you will do is welcome drink is 30 that you can split. 10 plus 20 is also 30, right? So 10 weeks after resection, that is like 2.5 months after resection, the patient is given 20 dives. You do the reconstruction part, surgery. A titanium implant has to be kept, or a mandible or the condyle, everything has to be regenerated. Implants, titanium implants of the TMJ, whatever, if the resection, hemimandibulectomy was done, whatever was done, you give 20 dives, do the surgery, and then you give remaining 10 dives. So that is the end of the treatment, because an implant is kept, so there is no story of progressing further. So stage 1, only 30 dives, re-evaluate, healing, give 30, send home permanently. Non-healing, give 30, bring to stage 2. Stage 2, 30 dives, do sequestectomy and primary closure. Recall the patient after some time. Healing, very good, give 30 more, treatment close. Non-healing, give 30, come to stage 3. Stage 3, give 30 dives, resection to healthy bleeding. Then give 30 more, end of stage 3. Stage 3R, give 20 dives after 10 weeks, do the reconstruction surgery, and then give the 10 dives. So this is your marks protocol. So I hope you are understanding this. As this class is being recorded, you can play it again and again, and you can really learn the concepts very well. Right. So dear students, do you study any of these questions? So if you are one of the person who is like this, please stop it, because you see the first diagram, you start your preparation like this, then you go like this, position changes like this, and suddenly after 10 minutes, when you are very excited, super excited to study, after 10 or 15 minutes, what happened? The book disappears from your hand and you are just flat. So always while studying, sit on a chair, have a table, and face towards a wall. Don't face towards the door, because if some movements are happening, people are coming and going, it will disturb you. Always face towards a wall where nothing else is seen in front. Before starting, put a dot on the wall at your eye level and just concentrate on that point. So it is just like bringing all the energy and concentration, and then you start your preparation. This is how you can start your concentration levels. So this is one more method how not to move from the position of study. Well, this is just on a funny part. This cannot be done, right? The best way of having a good concentration is having a very willpower and do micro studies. Okay, you don't plan 4 hours I will study, 6 hours I will study. Every 1 hour you study. Generally, our human brain concentrates for 20 to 25 minutes. 20 to 25 minutes. That's it. So after 25 minutes, the concentration will go off. That is the time when you can take a micro break of 1 minute. And then again, come back to studies. Next question, golden hour. So what is this golden hour? This is a 3 marks question. This is from the trauma chapter. So whenever there is an accident and injury, what you have to do is the first 1 hour of an accident is called the golden hour. So in this 1 hour, minimum time you should spend on the scene, the patient, and you should do maximum treatment in the ambulance. And when the patient is taken to hospital, maximum treatment should have been given to the patient. So planning of treatment, there is primary survey, which includes airway, breathing, circulation, disability, and events and exposure. So that is primary survey. Secondary survey is AMPLE, AMPLE. Check for allergy, check for medication, check for pregnancy, check for last meal, and events and exposure. So primary survey, that is ABCDE. Secondary survey, that is AMPLE. Both the surveys you do, that is called as complete assessment. So this is your primary survey ABCDE, and secondary survey is AMPLE. You can take a screenshot of this. So this is what you have to do in the first 1 hour, and then you need to address the patient very fast. So there are 3 types of death: peak 1, peak 2, peak 3. Peak 1 is non-salvageable, where you can't do, instant death can happen. Peak 2 is salvageable, where you can save. The first 10 minutes after an accident or an injury is called platinum 10 minutes. Maybe there is an obstruction in the neck, something went inside. You just take the obstruction, done, patient is fine. He doesn't need any surgeries. Just you take out the obstruction. And first 1 hour is called golden hour. Peak 3 type of death is death after an accident, after weeks or months, days, weeks or months. So golden hour of trauma, this is the time concept in which it is important to get the patient to a facility. You have to shift the patient, do primary survey, secondary survey, stabilize the patient, and make sure the airway is patent. Airway. So stabilization of the patient is important here. Airway, breathing, circulation is immediately you need to give in 1 hour. Fracture reductions and all you can postpone for almost like 2 weeks. You can postpone. Life is more important. That is why airway, breathing, circulation. Next question, management of oral cancers. Very, very important. Oral cancers, right? Ameloblastoma, like anything, you can take out any cancer, benign, malignant, any cancer you take. TNM staging, you should write an answer there. So here, oral cancers are not managed by one definite treatment. So 4 different specialties of science are brought together and they treat oral cancers. So first is the mechanics. In the mechanics means you do it. So surgery is involved here. So 1600 BC, this was brought into management of cancers. Physics, radiotherapy, radiations, radiotherapy we give. Chemistry, chemotherapy. And biology, immunotherapy. So please understand, in a cancer patient, you need to do surgery, radiotherapy, there is chemotherapy, and there is immunotherapy. And there is combination of everything also. So it's like cancer is there, you have to fire different ammunitions, right? So all the surgery has to be done, first radio, chemo, right? Immunotherapy, and then surgery has to be done. So it's just like multiple ammunitions you should fire at. So whenever there is a cancer patient, a multidisciplinary approach has to be done. There is surgeon, pathologist, radiologist, oncologist, nurses are there, diagnostic team, nursing team, right, rehabilitation team. So this team has to function. This is an answer for management of oral cancers. Any cancer, the same answer you can write there. So let us start one by one. Chemotherapy we'll do first, then radiotherapy. Chemotherapy. So chemotherapy is what? The objective of adding chemotherapy, chemicals, medicines, chemotherapy is to promote the initial tumor reduction. A tumor is big in size, we bring it to a smaller size. Let the tumor not grow further. You want to cut the tumor. So chemo, C also, chemo, start with C, cut, C. You cut the tumor mass. So you reduce the size. And if possible, stop the early metastasis of the micrometastasis also of the tumor. So objective of adding chemotherapy is to promote initial tumor reduction and to provide early treatment of micrometastasis. You give these chemicals, chemotherapy, medicines, and metastasis also will be sorted out. 2 objectives, okay? Tumor reduction and treatment of micrometastasis. So this chemotherapy for head and neck cancers, you can give oral or parenteral routes. Then once you give these medicines or chemicals, it will go inside, these chemicals will go inside your body. There are cancer cells, there are normal cells. So the biochemical pathway is being affected in that patient. And all the tumor cells are attacked, they become dead, and tumor cells reduce in size. So this is the basic concept of chemotherapy. You can take a screenshot and you can write this. So this chemotherapy or chemotherapeutic agents which affect the biochemical pathway. So there is a cell, the cell has so many reactions. There is electron transport chain happening, there is glycolysis, gluconeogenesis, all the first year cycles, what you know, everything is happening inside the cell. They all get affected now. Because there is cell replication and DNA synthesis is happening. So you give this chemotherapeutic agents, chemotherapy, the biochemical pathway changes. So you have got alkylating agents, antimetabolites. Examples are here. What they do? They damage the DNA, the disturbed DNA of the tumor cells DNA, it will cut, which will lead to death of the cancer cell. So examples are cyclophosphamide, cisplatin. The antimetabolites are 5-fluorouracil and methotrexate. So please learn these names. Okay, some names you should write. Then you've got anti-tumor antibiotics, mitotic inhibitors, and miscellaneous you have. So types of chemotherapeutic agents, just the names are enough, no need to go in detail. The chemotherapy can be of 6 types: induction, concurrent, adjuvant, palliative, intralesional, topical. So these are 6 types of chemotherapeutic agents. Complications of chemotherapy is loss of hair, right? Alopecia will happen, bone marrow suppression will happen, bone marrow suppression. That's why the stem cells needs to be preserved. Then if the bone marrow suppression is there, patient can, bone marrow, the cells are there, your RBCs, WBCs, all are made there. That gets suppressed. So patient anemia can develop. So there could be mucositis, nausea, vomiting, and even the reproductive functions also gets affected. These are the complications of chemotherapy. So you have to do a lot of precautions before the chemotherapy is given. All the dental extraction, restoration, fillings, everything should be done before chemotherapy. During the treatment, if cancer treatment is taking place, mucositis can happen. So chlorhexidine mouthwash should be given. If there is lot of bruises or ulcers or pains are there, ice cold water should be given. Lidocaine gels can be applied to reduce the pain, and candidiasis can develop. So fluconazole, and denture should not be kept in the mouth in the night. It should be stored in 1% hypochlorite solution during the night. And acyclovir antiviral drugs also you can give for herpetic infections. This is during the treatments. So see how you have to write an answer: before chemotherapy, during the treatment. And after the chemotherapy is done, oral hygiene index should be checked, and you should always, patient should continue to have anemia, bleeding tendency, infections. There will be, you need to address that. So what is chemotherapy? Chemotherapy we understood. What are chemotherapeutic agents we understood. The mechanism of action we understood. And then before chemotherapy, after chemotherapy, during the chemotherapy, what dental precautions you need to take. So chemotherapy is the use of chemicals in cancer treatment. Second one is radiotherapy, radiation. So the purpose of radiation is curative, it will cure, and palliative, give a soothing effect and happy effect for the patient. So this radiotherapy is generally given by external beam from outside. External beam using electromagnetic radiations or particulate components. So like your OPG machines are there or IOPA machines, from outside, you are going to get that radiation for these patients. So X-rays are used and gamma rays are used. Cobalt 60s are used. Okay. So the radiation sources, what you are going to give to the patient, they can be low kilovolt, electron beam, neutron beam, or mega voltage radiations. So these are the different types of radiation sources. Even if you don't write this BDS paper, it's still okay. Now, radiotherapy, radiation, two types of radiation therapy you can give. One is called teletherapy. See, teletherapy means what? Telephone. Telephone someone has to do from outside, right? So it is called external beam therapy. So external beam therapy is called teletherapy. So from one machine you are going to get. The second option is brachytherapy. Brachytherapy means these radioactive materials are kept inside the patient's body. A small incision surgery is done, they are kept inside. So slowly, the radioactive substance will be liberating its effect. It's like an implant therapy inside the patient. So teletherapy is external, internal, implant is brachytherapy. So this is example of teletherapy. A patient will lie down, only that area which needs to be, what you say, radiographed, or which needs to be, radiation has to take place, that area will be focused. Other than all, the lead aprons will be kept and a lot of precautions will be there. Brachytherapy, I told you, it's an implant which is kept inside. So these implants are interstitial or intercavitary implants. So radioactive substances are used. Radium-226 and iridium-192 are used. So what they do with a loop, they take it, the implant material, and insert it inside the cancer cell, cancer mass. So slowly, this material, radioactive substances releases, and then radiation is delivered continuously. So 24 hours, 7 days a week, the radiation is being given to the tumor cells. So the tumor cells reduces in size. Brachytherapy, patient has to go to hospital. Here in the home also 24/7, it is inside the patient's body. So this is how you have to do it. If the patient is in T1 or T2 condition, TNM staging, early stage of cancer, then you can respond equally well to radiations or surgery also. Radiation also, this will work. If large tumors are there, T3 and T4, then radiation alone will do. And preoperative radiation is given in attempt to shrink large tumors. Big tumor is there, preoperative, bring it to smaller size, do an operation, remove the tumor sites. Then the recent advances in radiotherapy, 5 types. No need to go in detail, just the names will help. If you can have time, you can read this. So oral complications of radiotherapy. Week 1, there could be nausea, vomiting. Second week, mucositis can develop. And third week, dry mouth can happen. So these are the precautions and the do's and don'ts before the treatment. A patient undergoing radiotherapy, oral hygiene procedures and restoration should be done. All scaling, filling, extractions, everything should be done. Radiation is going on and you do extraction, osteoradionecrosis, again hyperbaric oxygen. So that should not be there. It should be done 2 weeks prior. During the treatment, radiotherapy is happening, mucosal and salivary gland protection should happen. Discourage smoking, drinking, treat mucositis, antifungal agents, right? And salivary substitutes. There will be xerostomia. So salivary substitutes like carboxymethyl cellulose needs to be given. And jaw opening exercise also needs to be encouraged. After treatment, oral hygiene should be maintained. Denture should be given after 4 to 6 weeks. And if extractions are unavoidable during the radiation time, then make it atraumatically as possible. Don't give flap, bone cutting and all. Atraumatically take it out. And preoperative 48 hours before start the antibiotics. The clindamycin also you can give. And after the extraction, if required, hyperbaric oxygen therapy can be given to the patient. That is for those patients during the radiation therapy is going on, they need an extraction. So chemotherapy, radiotherapy. Next is surgical. So surgical means you are removing the mass and sending it for what you said, the diagnosis. So diagnosis and staging will be done. You will remove the mass, removal of metastatic disease. So it's a palliative treatment, preventive, and even reconstruction needs to be done. So basically, surgery is the definitive treatment. So surgery includes you remove the tumor mass. Along with the tumor mass, if you are removing a tumor from the maxillary mandible of the face, you have to do the lymph node dissection because metastasis will be there. Management of the neck comes here. And then reconstruction also needs to be done. So enucleation, curettage, marsupialization, which is there for cystic management also. Then you have to resect. This is very important. Whenever management of tumors happen or cancer, they ask this slide what is there right now. This you need to write. Resection without continuity defect. The lower border of mandible, it is intact. So you are removing the mass. So this is without continuity defect. It's not broken. With continuity defect means there is a breach. There is a breach in the lower border of mandible. So resection with continuity defect. And disarticulation means removing the whole tumor by condyle coronoid process. You are going to take it out. The whole articulation you are going to take it out, and you are going to reconstruct with the implant. That is a titanium implant or something like that. Tantalum you can put there. So in the management of oral cancer surgeries, maxillectomy. So Weber Ferguson incision you should read here. Mandilectomy, removal of the mandible. Glossectomy and radical neck dissection has to be there. So radical neck dissection, you have got level 1, 2, 3, 4, 5, 6. This is very important. Whenever you are going to remove any cancer mass anywhere in the head and neck, lymph node dissection needs to be carried out if it is a malignant tumor. So level 1 is here. That is your submental and your digastric region. Then level 3 is upper jugular lymph nodes. Upper jugular vein, upper part. Level 3 is the middle jugular. Level 4 is the lower jugular. Level 5 is the posterior compartment. Level 6 is the anterior compartment. So please, you need to write this. Without this, your answer is incomplete. And when you are doing neck dissection, you have got radical neck dissection. Radical means you are removing everything. Sternocleidomastoid, your vagus nerve, your accessory nerve, everything you are going to take it out. Modified radical neck dissection means selective. Sternocleidomastoid muscle, spinal accessory nerve, jugular vein, everything you are not taking out. Selectively you are taking out. So that is in the selective neck dissection, you have got this all options. So learn this very well. So in the modified radical neck dissection, you remove all these three: spinal accessory, sternocleidomastoid, interjugular. In the MRND, modified radical neck dissection 1, like their modification, you preserve one spinal accessory nerve, you preserve, other two you take it. MRND 2, you preserve sternomastoid and remove 1 and 3. MRND 3, you preserve internal jugular vein and remove other two. Whichever is involved, that only you have to remove. Just for us, even if this suppose spinal accessory nerve is not involved in the tumor mass, but it is there, not involved. Why you want to sacrifice it? Because once you do it, patient will be lifelong, will have a wry neck, torticollis like this. Patient's neck will collapse. So for the radical neck dissection, the three incisions are McPhee's, that is on the A diagram. Tri-radiate incision is the B, and Hayes-Martin is the C. Then you have to do reconstruction, immediate reconstruction. Advantage is same surgery. When you remove the mass and everything is disarticulated and done, that early return of function will be there. But the disadvantage will be if you are putting a graft, the graft may reject also. Loss of graft or infection can also develop there. So always go for a delayed reconstruction. So something like this. See, whole disarticulation was done on one side. So it's been articulated. Delayed reconstruction. So this is all about your management of cancers, right? Chemotherapy, radiotherapy, surgery, and immunotherapy is also there to boost up the immunity and all. So dear students, while studying, even staring at the wall becomes very interesting, right? Apart from the books, anything else in the world, you feel lot of sleepiness. During the exam time, we feel lot of sleepiness, and we feel that after exam, I will sleep for 2 days, I will not get up. And take it in writing, the day you finish your exam, you will not get sleep for next 2 days. Now you may be feeling a lot of tiredness and sleepiness. That is because lot of pressure you are taking. So you should have a proper sleep. Night, at least 6 hours you should sleep, and afternoon time, not sleep, but a short nap you can take. So at least 6 to 8 hours. 8 hours is too much during the exam. 6 to 7 hours of sleep is good for your health. That you can split it up. Afternoon, half an hour, just a nap, and night, 6 to 7 hours. And please understand, we forget 82% within 24 hours. So if we don't revise, we keep forgetting that. Whatever we read now, after a few days it is here. But if we don't revise, the memory comes down, down, down. And in the exam, we recognize, yes, I have read this question. It is there in that book. It is there in that paper, that down. But what is that answer? I don't know. That is because you only recognize, but you don't remember the answer. So revision is the key. Next question, Lincoln's Highway. Lincoln's Highway. So this is from a very important 3 marks question, and many students leave this question. The moment they see, they don't know where from this question has been asked. Now you see this diagram. This is the area where Lincoln's Highway is. So Lincoln's Highway is like Abraham Lincoln. In America, that is a national highway. We have a national highway in India. Similarly, in America, that is the longest highway. So a space infection in one part, it travels a lot, right? So very fast, rapidly spreading space infection. So because the national highway in America is Lincoln's Highway, so they made it, they termed it as Lincoln's Highway. So first and foremost, you should know that the spaces with the space infection, you've got normal anatomical space and potential spaces. Normal anatomical space means because of the structures which are present in the body, the spaces are there. Potential spaces are only when a pathology is involved. Whenever there is a infection, then only the spaces come into picture. Otherwise, this space doesn't exist. That is called potential spaces. Now, this is the classification of space infection above the hyoid bone, below the hyoid bone. You can classify in many ways. So, this is spaces limited to above the hyoid bone. So, Lincoln Highway comes here. Spaces involving the entire length of neck. So please understand, limited to above the hyoid bone, below the hyoid bone, second, and third one, entire length of neck. So here, this visceral vascular space, carotid sheath, this is your Lincoln's highway, the entire length of the neck. So you can take a screenshot of this. This danger space is also important question. The other method of classification which you would have studied, maxillaries, space infection, mandibular, and secondary. Okay. So there is one classification called Brodensky and Holekes method of classifying space infection. Space 1, 2, 3. So space 1 is superficial to superficial fascia. Space 2, surrounding the cervical strap muscles, neck muscles. Space 3 is Lincoln's highway. So this is what you have to write. So these are the space infection, superficial to visceral division of middle layers. It contains pretracheal, retropharyngeal, lateral pharyngeal spaces. In your first year anatomy, you would have studied carotid sheath, prevertebral layer, investing layer of deep cervical fascia. So all that diagram, if you can recollect from Chaurasia book, all the space gets involved over here. Pretracheal, retropharyngeal, lateral pharyngeal spaces. So space 3 is that. And 3A is called Lincoln's highway. It's formed by all the 3 layers of deep cervical fascia. Pretracheal, retropharyngeal, lateral pharyngeal space. This, you have to learn this. This is a 3 marks question. And space 4 is called danger space. Potential space between alar and prevertebral region. So I hope you understood what is Lincoln's highway. The diagram, investing layer, pretracheal, prevertebral layer, take out from your first year Chaurasia book, and even in oral surgery books, if we have, draw some diagrams and do a research around this topic. And again, this pterygomandibular space, because we are discussing space infection, very commonly they ask. So the contents of pterygomandibular space, a mnemonic M.mil. Mandibular nerve, mylohyoid nerves and vessels, I, inferior alveolar or mandibular artery, lingual nerve, loose alveolar or connective tissue, fats. M.mil is the abbreviation here. It will be very useful. It's a 3 marks question. You can remember this. So this is your Lincoln's highway. This diagram you can draw. So contents are carotid arteries, internal jugular vein, vagus nerve, everything, sympathetic plexus, the whole neck is involved over here. This is the diagram, what I am talking from the first year book. You can take a screenshot of this also. Next question, anterior maxillary osteotomy. Now a patient, this is an orthographic chapter question. Now a patient is having a problem in the occlusion. Only the anterior, upper anteriors is a problem. It's too much inclined, or it is frostbite, or it is little deviated. It's the problem is localized and it is only in the anterior part of maxilla. Normal occlusion is there on the molars. So what you have to do is you have to extract the first premolar. So before coming into that question, surgical options for maxilla we have got Leaford 1, 2, 3. For mandible we have got BSSO, vertical ramus osteotomy, genioplasty, segmental. So this is the surgical options for our orthodontic surgeries in maxilla and mandible. Now osteotomy of the midface. So this is, I'm talking about anterior maxillary osteotomy, AMO, that is the front part of the maxilla. Now what happens, as I told you, there is a isolated problem. Posterior occlusion is perfect. So now what you have to do is you have to extract the premolars from the both the sides. First premolar here, first premolar here. Reflect the flap, extract the premolars, and then with your burr, do a vertical osteotomy cut. And then make a horizontal osteotomy cut, taking precautions of the nasal aperture and all. So it's just like a goalpost is created. Once you extract the teeth, so now in the anterior maxillary osteotomy, you've got two techniques: Wasserman technique, Wanderer's technique. So this is the one what we are discussing right now. Osteotomy of the midface, this is one option. Then you got posterior segmental osteotomy, Leaford 1, 2, 3 osteotomy. So this red one we are going to discuss. Now please understand the blood supply of maxilla. You have got maxillary artery, facial artery, external carotid artery branches. These are the ones which supply the face. So always remember, whenever we are giving an osteotomy cut, the one side the blood supply has to be intact. You will not cut through and through. Like buccal and the palatal, you will not cut. Either you will cut buccally or you will cut palatally. If you are cutting buccally, blood supply should be intact from palatal side. If you are going to give a osteotomy cut on palatal aspect, then the blood supply should be intact on the buccal aspect. So this is how you do this. This is for an anterior tooth. I'm showing. So anterior maxillary osteotomy is done for bimaxillary protrusion, open bite cases, when orthodontic treatment or the tooth movement is not possible. Right, so those are the ones where the surgery needs to be done. As I told you, extract the first premolars, do a vertical osteotomy cut, and then through and through you will cut. Now you have got two techniques, Wasserman and Wanderer's technique. Wanderer's second letter is U and buccal second letter is U. Wasserman second letter is A, palatal second letter is A. So this is a mnemonic what I am going to give you. Blood supply intact. So that means in the Wanderer's technique, the second letter is U, so the buccal surface is intact. Buccal surface is intact. So blood supply is from the buccal surface. So where should be the osteotomy cut? On the palatal aspect. In the Wasserman technique, the blood supply is intact on the palatal aspect. So the osteotomy cut is given on the buccal cortex. You will not cut the buccal and the palatal cortex together. Only one cortex will be cut, and then the fragment will be moved. Right? If it is excess, then it will be trimmed, because you are giving a horizontal cut also here. It will be trimmed, and then the proper occlusion will be maintained, and like fracture plating, how you do with the mini plates, like that mini plates will be kept. So transpalatal injection. So the basic concept I have explained you. Just go back and read the theory part little more. So this will help you to understand. Wasserman, palatal aspect is intact, buccal plate you are going to cut. There is one more method called Cooper's method, which is buccal vestibular incision here. So here horizontal osteotomy is followed by vertical. Same thing we are doing there also. First there we were doing vertical osteotomy, and then we were doing horizontal. So here first horizontal followed by buccal. The complications of anterior maxillary osteotomy: the tooth vitality can be hampered, periodontal defect can come, and communication, because you're going to cut here, communication can happen with the nasal cavity, or antrum maxillary sinus also can get involved over here. Or step formation defect can also happen. So this dark green area is the one where we are going to do this anterior maxillary osteotomy. So premolars are extracted, a vertical cut is given, horizontal cut is given. The premolars are extracted, you can see here, and then if it is backward, it can be moved forward and brought into an occlusion. So even the crossbites can be corrected. If it is too much procline, it can be brought back, and then a normal plating is done. So now revision. So whichever things you are finding it difficult to revise, when you study the whole day, always close the book and start recollecting what you have studied today on the whole day. So always you should revise first for 1 hour, then the next day, then after 2 to 3 days, the next month, the next week, next month, and 6 months later. If the constant revision is there, you will never forget in the life. Always have a revision wall, something like this. So now you're just 10 days away, but still time is there. Anything which you find it very difficult, write it down, stick on the wall, and keep reading it again and again. So the ninth topic of the day, Waldron's technique. So this is very simple technique actually. So Waldron's technique is nothing in the management of cyst. It comes PARS 2. So this is generally marsupialization. Whenever there is the cyst is near to a vital structure, we can't remove the whole structure of the cyst because the vital structures may get hampered. So we open the cavity and suture it. Openings we suture to the other side. That is called marsupialization. And when the cyst reduces in size, we do enucleation. So please remember, marsupialization followed by enucleation. M-E, me. Marsupialization followed by enucleation is the Waldron's technique. Very important 3 marks question. So you have to draw diagrams also here. So you do marsupialization, that is decompression, followed by enucleation. So enucleation can be with packing, with primary closure, with bone grafting and all. So just remember me, it's a 2-stage technique. First is marsupialization, second is enucleation. So you can write about marsupialization and enucleation accordingly. So indications and contraindications. Then coming to the last question of the day, Burns hypothesis. This question comes in exam. Basically, some students get confused. What is this Burns hypothesis? This is nothing. Dry socket. Dry socket. The dry socket means what happens is you do an extraction, patient is fine. After 3 days, he comes and says severe pain. And when you see that area, the clot is gone. There is no clot over there and the bone is exposed over there. So that is the problem. The clot is not being formed. So this flow chart or this what you are seeing on your screen, this you should know what is happening. The clot gets dissolved. What happens in your normal clotting procedure? There is a plasminogen. Plasminogen, right? That is your factor 2. So what happens? In the plasminogen will get converted to plasmin. This is the normal thing. But your enzyme, urokinase and tissue activators will act. Activator enzyme will act here. And then antiplasmin will come into action. Because of streptokinase, tissue kinase, indirect activators. So you've got direct activators, indirect activators. They will all act in the conversion between the plasminogen to plasmin. So a proper plasmin is not formed and antiplasmin substances are liberated. So what happens? The plasmin gets converted to fibrin. From fibrinogen, fibrin happens. So this is not taking place properly, and whatever fragments are clotting is done, that breaks off. Take a photograph of this. So this is also called as alveolar osteotitis, dry socket. So it's a painful condition. 3 to 5 days, patient will come. Generally, after extraction, the blood will come and it will heal. That is the normal healing. But in dry socket, the healing doesn't take place. Right. So loss of blood clot is the problem over here. So this is what 1 day after extraction, then normal angiogenesis takes place, bone formation takes place, then a new bone will form. So this is the normal thing what you see after every extraction. So here what the problem is happening is the plasminogen to plasmin, and then plasmin is responsible for the conversion of fibrinogen to fibrin. That is the problem here. Lysis of fibrin takes place. Lysis of fibrin. Take this photograph, very, very important. You do an extraction, blood comes. In the blood, there is plasminogen. From the plasminogen, plasmin is formed. Plasmin is responsible. It is required for the conversion of fibrinogen to fibrin. The main defect is taking place here. Loss of fibrin takes place. And the whole clot is gone. So this is called dry socket or Burns hypothesis. I'm not discussing the dry socket management. I'm discussing Burns hypothesis. The same thing, you can express the same mechanism in different flow charts. This is your flow chart for Burns hypothesis. You can take a screenshot for this also. So signs and symptoms, severe pain, inflammation will be there, bad smell, halitosis, foul taste in the mouth, bacterial contamination, and if the smoking is done, it will aggravate the problem. We should tell the patient not to smoke. You should things to avoid is rinsing the mouth. Straw should not be used. No strenuous exercise should be done, right? And no sticky food should be allowed. So management, antibacterial substances, analgesics, fibrolytics, antifibrolytics, fibrin stabilizing agents. So what was the etiology of Burns hypothesis? You are treating that. Antiseptic, Surgicel, and obtudent dressing can be given. So complication, it can even lead to osteomyelitis. So dear students, do not waste your time in WhatsApp, in Instagram. Just for relaxation, I will see 5 minutes, 10 minutes, and this 5 minutes become 10, 10 minutes becomes 20 minutes. So do not waste your time here. Please change your attitude. You have to fight till the last ball. Right? This 10 days, the whole world will rotate around the sun 10 times. You can change anything. Right? So change your attitude. Right? Changes happen personally from inside out, and always have a positive image that yes, you are going to pass, and this is for the last time you're writing exam. Imagine the last time. After that, there is no more exams in your life. What a feeling it will be. You started in your schools, LKG, UKG, and now you have reached to the pinnacle, the finals of finals. So change your attitude. 3 things you have to change: attitude, behavior, and thinking pattern. It's all from inside. If you think you will clear the subjects, you will. So always think positive. Your attempt may fail, but never fail to make an attempt. Okay, it's very, very important. Never fail to make an attempt. So do everything, whatever is possible. Please do not accept the false boundaries and limitations created by the past. Initially, you would have got a supply paper. Does not mean that this year you will get. Until you write the exam, nothing is confirmed. So read everything. You never know the question what you read towards the end. That only comes in the exam. Always keep trying. That's all. The choice is yours. With a bad attitude, you can never have a positive day. With a positive attitude, you can never have a bad day. The choice is yours. This time, like all the times, is a very good one if you know what to do with it. So dear students, your time starts now. It's been 1.5 hours exactly now. I was a little quick because I don't want to take much of your time for discussing 10 questions. The time starts now. So what you need to do is just 10 questions, go back, and the main question, sit another 1.5 hours and revise this question. So once for all, this 11 questions are over for your exam. Trust your abilities. A bird sitting on the branch of a tree doesn't get scared if you shake the tree, because it doesn't trust the branches, it trusts its wings. Question paper can be tough, right? Your preparation should be such a way that even if tough question paper, you should be able to get very good marks. So trust yourself, trust your preparation. So have a wonderful and a positive future and enjoy. So all the questions are welcome. If any questions are there, you can post it to me or in the WhatsApp group, because the time is already late. WhatsApp group, we are there, right? And to mentors are there, a team is there, and DSA people are there. So I hope this class is useful for you. To give your feedback, valuable feedback. So it's always important. With your feedback only, we try to improve. So once again, I thank Edin2 and DSA for organizing such a beautiful thing called revision series before the exams, so that in a very quick time, a lot of concepts can be revised. So I'm always there for you people. Contact the Edin2 team and get back to me. So all of you, thank you so much. Good night.